Okay, so the today topic is the management of nausea and vomiting of pregnancy and hyperemesis gravidarum. So introduction and background epidemiology. Introduction. Nausea and vomiting, it is affecting 80% of the pregnant women, and it is the most common indication for hospital admission among pregnant women. Again, I highlighted this one because whatever the most common, you have the chance that you will get this question in the exam. So what is the most common indication for hospital admission is the nausea vomiting of the pregnancy, with typical stay of between 3 and 4 days. Okay, also I want you to focus nausea vomiting of pregnancy is different terminology. It is affecting the 80% of the women. And the hyperemesis gravidarum, it is 0.3 to 3.6% of the pregnant women. So both things are different. If they're asking you the most common indication for hospital admission, if there is a hyperemesis gravidarum, don't pick that one. Please pick the nausea vomiting of the pregnancy. Don't confuse this incidence. So nausea vomiting is defined as the symptoms of nausea and or vomiting during pregnancy where there are no other causes. And hyperemesis gravidarum is the severe form of nausea vomiting of pregnancy which affect about 0.3 to 3.6% of pregnant women. And reported recurrence rate vary from 15.2% up to 81%, with the self-reported studies shows that 81% if using the self-reported diagnosis. So it's a very huge range, 15 to 81%. So it's whenever they're asking you the questions in which they ask about the patient is coming to you and she's very worried because she has previous history of hyperemesis gravidarum, and now she want to ask you. So in the options, maybe they will ask you that, okay, maybe you consult the patient that in this pregnancy, she has a very high risk of recurrence. So that's why this line is important, and we will discuss later on how we are going to answer this one. The etiological theories for nausea vomiting of pregnancy and hyperemesis ranges from the fetoprotective and genetic to the biochemical, immunological, and biosocial. So they said because it is due to rising level of beta HCG, and any condition which have high beta HCG like trophoblastic disease, multiple pregnancy, it is associated with increased severity of nausea vomiting of pregnancy. So in the guideline, they just mentioned the terminologies and they didn't go into the detail, the etiological theory. So we don't need to do also this one. Diagnosis, how to diagnose? So nausea vomiting of the pregnancy is only be diagnosed when onset is in the first trimester of the pregnancy and other causes of nausea and vomiting has been excluded. So if in the exam they give you a 14 weeks pregnant woman, she came with vomitings, and there is any, they will give you the scenario that it is not responding to the routine antiemetics, then you should not select this one, nausea vomiting of pregnancy, because it is diagnosed only when onset is in the first trimester. So you have to think about of other causes also. Maybe she has infection, or maybe she has gastritis, or the upper respiratory. There are some differential diagnoses with nausea vomiting. So you have to think about the secondary causes, because nausea vomiting, its onset is always in the first trimester. And when you have excluded the other causes of nausea and vomiting. So once it looks very simple when you are taking when you are reading the guideline, but when actually the questions coming, you forget that it's written in here only be diagnosed. So diagnosis is very important. Onset of nausea vomiting is in the first trimester, and if the initial onset is after 10 weeks and 6 days, other causes need to be considered. It typically start between 4th and 7th week of gestation, peaks in approximately 9th weeks, and resolve by 20 weeks in 90% of women. So there was a recall, or there was SBA. So they ask about what is the peak time of nausea vomiting. It is 9 weeks. And when it is usually started, it is between 4 and 7 weeks of pregnancy it starts. And it is resolved by the 20 weeks. Sometime they will give you 4 week and 7 week also. So this is the problem. You will select the 4 week and 7 weeks. I don't know anyhow if they will ask it starts, so you have to select the 4 week because it can start from the fourth week. Okay. So hyperemesis is diagnosed. It is characterized by triad. It is there is a severe protected nausea and vomiting, which is associated with weight loss of more than 5% of pre-pregnancy weight, dehydration, and electrolyte imbalances. So there are three things. If you get the three things, then you will diagnose this one. The first is severe nausea and vomiting. The second is weight loss of more than 5% of pre-pregnancy weight. Please focus on the pre-pregnancy weight. And then the third one is dehydration and electrolyte imbalance. This is the triad of hyperemesis gravidarum diagnosis. So there is an objective and validated index of nausea and vomiting, which is called the pregnancy unique quantification of emesis. So you can use this one. Okay. Okay, you can use this one for the classification of severity of nausea and vomiting. With PUC score, you can easily quantify it, either it is a mild, moderate, or severe. Okay, and there is another index. Sometime in the exam or in the SBA books, they are asking about this Rhodes index. Actually, it was initially for using the symptoms of chemotherapy patient, and they are using this one Rhodes index. But now they have been using for nausea and vomiting also, and also they are using before for the physical symptoms and resulting stress plus nausea and vomiting. So whenever they're asking you what is the another validated objective index for nausea and vomiting, you can choose this Rhodes index. So shortest disease specific questionnaire, because PUC score is a questionnaire. They will give you the questionnaire and they will ask you in the last 24 hours some symptoms, and if according to the severity of the symptoms or frequency of the symptoms, they will assign some numbers. And then you will calculate, okay, the total number now according to those symptoms, is it less than 13, or so it is mild, is it more than 13, it is moderate, or like that. This is a questionnaire type of question. um, okay, so okay, actually when I'm admitting the pupil, I'm confusing myself. It's very distracting really. Okay, the PUC score can be used to determine whether the nausea and vomiting is mild, moderate, to severe, and can be used to track progress with treatment. I highlighted this one because it is not only used for to diagnose the severity, but it can also be used to track progress with treatment. You start some treatment and now you want to see that now the PUC score is less than 13, so it is now coming into the mild category. So whether you can discharge the patient in the community, or whether you can ask the patient to come back. Yani this will help you also with the progress with treatment. If some question is asking that the PUC score is for the severity, and you can also correct yani select this option that PUC score can also be used for tracking of progress with treatment. So how can the severity of nausea vomiting be classified? What initial clinical assessment and baseline investigation should be done before deciding on treatment? So first of all, you have to do history, examination, investigation. Then it will allow you to assess the nausea, vomiting, hyperemesis to be assessed and diagnosed, and for their severity to be monitored. So there is a very nice chart you can see here. Okay, so this is first of all, whenever there is a patient who came to you in the ER, for example, she is 9 weeks pregnant and she came with nausea and vomiting. First of all, you will ask them if she has previous history of, first of all, definitely will ask if she has nausea and vomiting. Did she has in the last pregnancy, she has the same problem? Then you classify her symptoms, either nausea, vomiting, hypersalivation, spitting, loss of weight. Yani, there are some questions you will ask those questions which is present in the PUC score, and in the PUC score these questions are nausea, vomiting, how many episodes, hypersalivation, spitting, loss of weight, inability to tolerate food and fluids, effect on quality of life. So you have to ask all these questions from her. Then you will ask other questions which will rule out other causes. For example, you will ask about abdominal pain, any urinary symptoms, any history of fever, infection, any drug she's taking, or any previous history of Helicobacter pylori infection or previous history of gastritis. So in the history, you will ask these questions. In the examination, you will take the vitals, oxygen saturation, respiratory rate, abdominal examination. Abdominal examination, you will see if there is any sign and symptoms of acute abdomen, why she's vomiting. So definitely abdominal examination you will do. You will weight the patient, then you will see the sign of dehydration on the mucosa, on the tongue, on the skin, and then you sign of muscle wasting and other examination as guided by history. So this is the general examination you will do. Investigation, you will give the patient dipstick and you want to see whether the ketonuria is there or no. And then you will do urea and electrolytes. In urea and electrolytes, you want to focus about the potassium, whether it is low or high potassium, low sodium, or dehydration, and renal disease, any sign of renal disease, creatinine is high or anything. Then CBC, in the CBC, you want to see three things: infection, so you will see the TLC count, hemoglobin, anemia, and hematocrit, you want to see the dehydration. So in the CBC, you want to see these things. Then you will see the blood glucose monitoring, because definitely any patient with nausea and vomiting first time, maybe first time she present with DKA. So even you will check the baseline blood sugar and you will exclude the DKA if diabetic. Even not diabetic, you will do blood sugar also. Ultrasound scan, you will confirm the intrauterine pregnancy, you will exclude the multiple pregnancy and gestational trophoblastic disease, okay? And in refractive cases or history of previous admissions, you will check you, because if the patient is coming recurrent, this is very important. If they will give you the patient have repeated admission in the ER and now she's coming to you, so what investigation you want to do? So if they will ask the question like that, you can just do this thyroid function test, hypo or hyper, you want to exclude this one. And also you want to do liver function test, you want to exclude the liver disease such as hepatitis or gallstone, or you want to monitor the malnutrition. So actually, these type of chart looks very simple, but when they are writing something very small and in the end, for example, refractory cases or history of previous admissions. So this is important. In this case, you want to see the EMQ, you want to see the thyroid function test first of all, or you want to see the liver function test, because these are the baseline investigations. Already, if she's coming repeatedly, definitely the history and examination and investigation already has been done, and definitely no definitive diagnosis was given to her, and she is supposed to be nausea vomiting of pregnancy or hyperemesis gravidarum. But if she's coming repeatedly, then you will do this other investigation and you want to rule out another causes. So this is very important. Okay, so I already discussed the recurrence rate, and then the incidence of hyperemesis, it reduces in the second pregnancy if there is a change in the paternity compared with no change. So the SBA was asking that the gravida 2 para 1, she came to you and she's very worried because in the first pregnancy she has history of hyperemesis gravidarum. So what you will tell her, and in the option, they said we have to tell her the recurrence rate in this pregnancy is very high. And this is the correct answer. If, for example, if they want to twist it and they will say that she is married this is her second marriage, and she has a history of nausea and vomiting in first pregnancy. Now she came to you and she want to ask, is there any chance? So you have to tell her in this case that in the second pregnancy, if there is a change in the paternity, the chance is 10%. Is not like same. I think it is like preeclampsia with us. No, it's not like preeclampsia, because with preeclampsia, the second partner, the risk is increases. But here with the second partner, the risk is decreases. So it's something different. Okay, so nausea and vomiting and the hyperemesis, they have low sodium, low potassium, low serum urea, raised hematocrit and ketonuria, and with metabolic hyperchloremic alkalosis. So these are the things they are asking in the SBA, because I check some SBA books, and usually the questions are coming from this highlighted lines I highlighted for you. And in there you can see here it is a metabolic hyperchloremic alkalosis. Okay, but if they will give you if severe, then this alkalosis, it can convert into the metabolic acidosis, because definitely dehydration, more ketone urea, more ketone formation, so patient can end up in metabolic acidosis. So this may develop if it is very very severe. Okay, so just if they give you option of metabolic hyperchloremic alkalosis, okay, but if they will pointing towards very severe and she's vomiting and she's dehydrated and like that, maybe they want you to select the metabolic acidemia. So don't forget this option also. So in two-third of patient, there may be abnormal thyroid function test. Again, they ask like that, how much incidence if the patient have hyperemesis gravidarum, how much is the incidence that her thyroid function test will be abnormal. So two-third mean almost it is 66% or 67%. So you can easily select anything between 60 to 70%. You can select this option because 60 to 70% they will have this abnormal thyroid function, because TSH and HCG, the structural similarity. So the TSH will be also, it will be abnormal thyroid function. That means hyperthyrotoxic, yani, biochemical thyrotoxicosis. So TSH will be high, and sorry, I don't want to confuse you, but this TSH in the hypothyroidism, it will be it will be high.
Low.
Yes, yeah, it will be high.
Uh,
So it,
high.
yeah, it will be high. So it will be a biochemical thyrotoxicosis, and the thyroxine level will be high. So TSH level will be low, right? So in this scenario, you will see that the biochemical thyrotoxicosis with the suppressed thyroid stimulating hormone and high thyroxine level. Okay. So these patients rarely have thyroid antibodies and use thyroid clinically. Also, there was one question they're asking that how you will differentiate that this patient is having thyroid disease, or if it is due to hyperemesis gravidarum, the thyroid function tests are abnormal. So the main differentiating point is that thyroid antibodies.
Antibodies.
Yes, thyroid antibodies, they will not have the patient with hyperemesis gravidarum. They don't have thyroid antibodies. They can present hyperemesis gravidarum. The clinical features can present as they have thyrotoxicosis. They can present with high thyroxine. They can present with high TSH, but they cannot present with thyroid antibodies. So this is the differentiating feature. If this is the SBA question. So if you will repeat,
Low TSH.
sorry,
Thyrotoxicosis. Thyrotoxicosis was low TSH.
thyrotoxicosis, yes, TSH is low, suppressed TSH is low,
Yes.
and thyroxine will be high. Okay. So in this,
Okay.
yeah, because whenever you have high hypothyroidism, TSH will be shooting up. Okay, it will be, you will find
High.
35 or 65, yeah, because they are trying to produce more thyroxine. So whenever
Yes.
you have hyperthyrotoxicosis, you have low TSH, because the thyroxine will be shooting up and it is trying to suppress the TSH. So there is a difference. Okay, so the only difference is thyroid antibodies. Normal physiology, if you will open the normal physiology in the first trimester, in the start of the pregnancy, the picture is usually of thyroid, any hyperthyroidism. At the end of the pregnancy, the TSH, the normal physiological level, it is more towards the hypothyroidism. Okay, it is normal physiological changes. But the thing is, we have to see that the biochemical thyrotoxicosis, if hyperemesis gravidarum it resolve, it will also resolve. So maybe there is option you will repeat the test after some time and the thyroid function test become normal. So this full paragraph make one SBA. So you have to select the thyroid antibodies, because thyroid antibodies is the one who will present in the patient with hyperthyroidism. but not in the hypergravidarum. So treatment with the antithyroid drug is inappropriate. So you will not give the treatment. Liver function test also, this is another SPA questions. It's abnormal in up to 40%. And the most likely abnormality being a rise in transaminases. And somebody is asking which transaminases, then they're answering also it is alanine transaminases. Okay. So this is the one. So bilirubin levels can be raised also, but without jaundice, and amylase level can be mildly raised too. So without jaundice, bilirubin can also be raised, and as the hypergravidarum improve, these abnormalities will improve. So ultrasound next is the ultrasound. You have to do ultrasound for viability for gestational age, and you want to rule out the multiple pregnancy and gestational trophoblastic disease. And unless there are other medical reasons for an urgent scan, you can schedule as long as the nausea and vomiting has resolved with treatment. So if they will ask urgent ultrasound, or they will ask routine ultrasound, or they will ask the book appointment for ultrasound, so do routine ultrasound. There is no urgency of doing ultrasound in these cases. So sometime asking very simple question, you will do routine ultrasound, you will do urgent ultrasound, you will do routine ultrasound. So other pathological causes is peptic ulcer, cholecystitis, gastroenteritis, hepatitis, pancreatitis, and then you have this urinary tract infection or pyelonephritis, metabolic conditions, neurological conditions, or drug-induced nausea and vomiting. These are the differential diagnoses. And then severe abdominal or epigastric pain. This is very important because usually nausea and vomiting and hypergravidarum, it's not presenting with abdominal or epigastric pain. If somebody is presenting to you, then in that case, severe abdominal pain, you might want to do serum amylase levels and abdominal ultrasound, and you might possibly want to do esophageal gastroduodenoscopy, which is considered safe in pregnancy. So maybe in scenario, the patient came to you with severe epigastric pain, which is not resolving with the usual treatment, and maybe she's around 12 weeks, something borderline gestation, and you what next investigation you want to do. So maybe you want to select the abdominal ultrasound in this case because severe abdominal epigastric pain, or maybe you want to select the serum amylase. Because in that scenario, when they want to ask you the higher investigation, usually the baseline investigation being normal, or it, or maybe not normal, but anyhow they will guide you. They always their questions are very simple. They will give you all the information, and there is always some buzzword is there is always one clue that and that clue is pointing toward the diagnosis. So in this one, the buzzword is severe abdominal or epigastric pain. So this is the buzzword. If anything coming in the nausea vomiting scenario, and if they are giving this word, maybe they want you to select the amylase or abdominal ultrasound, or maybe even esophageal gastroduodenoscopy, which is considered safe in the pregnancy. So chronic infection, Helicobacter pylori, it is can be associated, and you can do H. pylori antibodies. You can consider to do. What is the initial management? Initial management. This is also the questions. I think in my exam, yes, in my exam, this question came to me. You may be all wondering, I remember all of my questions. Yes, I remember all of my questions. Why? Because when I give exam, when I'm coming back, the first thing, even if there is a break in between the two papers, so in between the break I was writing the questions which is coming in part one. So and even in the part one, I contributed maybe 130 questions. So this is the thing, I remember my questions. And uh, we are expecting all of you that when you go to the exam, you just write your questions. Why? Maybe God forbid, it's not for others, it's maybe for yourself also, maybe next time, because it's a very difficult exam. So yeah, or maybe your friends, they're asking you the questions, so yani, or maybe you want to give back something to your community who helped you for the exam. So the woman with the mild NVP, she should be managed with the community with the antiemetics. So if she's a mild one, the mild one will have only vomiting. Okay, she is having vomiting and she will not have dehydration. So what you can do, she can be managed in the community with the antiemetics. She will require only oral antiemetic support, reassurance, oral hydration, and dietary advice. So these are the things she need only, with the mild one, which have only vomiting without dehydration. Then there is a coming ambulatory daycare management. And ambulatory daycare management, when the patient, the general treatment, oral antiemetics and any support, reassurance failed. And when the puck score is less than 13, okay. So in this case, what you will do there, you will take the patient in the daycare management. You will give IV fluids, IV vitamins, multi and B complex, and antiemetics. So in this case, you can admit the patient as a day case, and you can give the IV therapy, or even antiemetics IV you can give. So inpatient management, which patient you will consider inpatient? This is the criteria. You can just remember it. If there is all patient cannot take oral antiemetics and she continue nausea and vomiting, and she has continued nausea and vomiting, and which is associated with ketonuria and or weight loss greater than 5% of body weight despite oral antiemetics, or she has confirmed or suspected comorbidity, for example, UTI, and inability to tolerate the oral antibiotics. So anything which is with complication for admission. This simple. Any patient with complication, she is for admission. Either this complication is dehydration, or she's having infection, or she's having to lose the weight, or she cannot keep anything orally. So these are all indication for admission to the inpatient management. So what therapeutic options are available? Okay, so first of all, we will discuss the safety and efficacy of the pharmacological agent. So we have the antiemetics. First of all, they give the antiemetics, antihistamines, which is the histamine H1 receptor antagonist. Okay, in this category, there is promethazine. Okay, I think in your hospitals, the promethazine, it is coming by the name of Finnergan. Okay, this promethazine, and cyclizine, then cynarazine, doxylamine, and dimenhydrinate. These are all antihistamine, and you can say it is histamine H1 receptor antagonist. These are the drugs usually we are using. So promethazine, we are using usually with the pethidine, like this is narcotic. We are using promethazine antihistamine as an antiemetic because pethidine is associated with vomiting. So we are giving along with this one, this Finnergan or promethazine. Okay. So again, this one we are using. The another I don't have. The cyclizine tablets we are using here, and the other drugs usually dimenhydrinate. It is usually present in the cough syrup. So maybe this one. Okay. Okay, then the phenothiazine, the another category is phenothiazine. The phenothiazine is prochlorperazine, chlorpromazine, and parafenazine. These are the names, okay? And then there is a dopamine antagonist, which include the metoclopramide, common name is Plazil, and domperidone, the name is Motilium. The Motilium tablets we are using for our patients. So these two medicines, it's available. It's under category of dopamine antagonist. So these are the three categories which is safe in pregnancy and we are using in the nausea vomiting. So there are some data, okay, safety data for first line antiemetics, for example, antihistamine and the phenothiazine. They should be prescribed. So because there is long-term data and their safety has been already be established. Then if the first line drug is not effective, you can go to the second line, then you can go to the third line. Even they are saying combination of different drugs should be used who do not respond to the single antiemetic, because different drug have different mechanism of action, so they will have the synergistic effect. So you can prescribe the combination of different drugs. They should not be a problem. Okay, so for women with persistent or severe hyperemesis, the parenteral or rectal route may be necessary and more effective than an oral regime. This is very confusing. EMQ can become in the exam. Maybe the only thing they want you to select parenteral or rectal route, or maybe they want you to select the rectal route. So don't forget about this statement whenever the patient is cannot tolerate the oral regime, and maybe they will say the patient is she has needle phobia. For example, patient is not tolerating the oral antiemetics and she has needle phobia. So they want you to select the rectal route. So don't forget this route, na? And with persistent and severe hyperemesis, this might be a good way. Or maybe patient veins are, maybe she's drug abuser, maybe her veins are very difficult to access. So in this route, don't you should not forget. So patient should be asked about previous reaction because there is drug induced extrapyramidal symptoms and oculogyric crisis. These are the drugs phenothiazine and metoclopramide. If you go back previous slide, the phenothiazine. So that's mean not only the metoclopramide but also the phenothiazine. They are also associated with the extrapyramidal effects. So this prochlorperazine and chlorpromazine and perfenazine, these are all also associated with extrapyramidal effect. We all know about the metoclopramide, but usually we forget about this phenothiazine. Phenothiazine also can cause the extrapyramidal effects, and I hope you all know the antidote. Anyone can tell me the name of antidote? Very difficult name, this one. Anyone? What is the antidote of this extrapyramidal side effect? Nobody knows. It's a very difficult name. I forget also, but it is something like uh, let me see. Anyone can just Google the antidote for this one, metoclopramide extrapyramidal.
Benstropine,
Sorry,
diphenhydramine.
no, 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 Benz, no, 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 no. It's not like
No,
that. No, 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 no,
it's
no.
like on Google, it's
I know the name, but
antipyretic.
I forget exactly the exactly name. Okay, just let me, because maybe
Clonidine, beta, like,
no, no, drug
no.
induced extrapyramidal side effect. It's a actually exam question, but I forget to put the name in the slide. So drug induced extrapyramidal um, treatment. Sorry, antidote. This is antidote. It's a something from pro antidote. Okay.
Try hexafenadile.
Huh?
Try
What?
hexafenadile.
Trihexy? No, no, no,
Fenadile.
no, no. You are telling me no, no, it's something from pro. Why am for this pro something pros? Sorry guys, I have this problem. If something stuck in my mind, I have to clear there and then. Antidote of metoclopramide. Uh,
Benstropine and anticholinergics are usually given.
which one? Which one you are telling?
Anticholinergic benstropine.
No, no.
Dr. Fozia, it may be diphenhydramine.
Diphenhydramine. No, it's
Diphenhydramine.
diphenhydramine.
Diphenhydramine. But
Yes, please.
is diphenhydramine is having another name? Because it was like something pro, and then there is something else. I remember because yesterday I was seeing, and I thought I will remember the name. Okay, just give me 1 minute. Mhm. Okay, I will come back to you because right now I will come back to you. I will tell you. Okay, we will just remind me at the end of this lecture. Okay. Um, Okay, so we have, if this occur, there should be prompt cessation of the medication. If, like the blood transfusion reaction, if you have something with something, first thing you have to do, you have to stop that transfusion. So you will immediately stop the medication. So clinician should be use antiemetics with which they are familiar and should use the drug from different classes if the first drug is not effective. Metoclopramide is safe, effective because of risk of extrapyramidal effect. It should be as a second line. It should be used as a second line. And also, ondansetron is safe and effective, but because data are limited, it should be the third line. They say in the guideline that it might be related to cleft palate, it might be related to some problems, but the latest,
Cardiac.
this skeletal problem, I think something related to that one. I didn't take that line. Why I didn't take that lines? Why? Because the latest data, the last webinar I attended, medical disorder in the pregnancy 2021. In that one lecture was only on the ondansetron, and they make this conclusion that ondansetron is a very effective drug, and we should not, we should explain the patient that there is very small risk of this side effects or this abnormality, but the majority of data is convincing that it is most likely any rare problem. So you cannot the doctor should offer this medicine without withholding, because this drug has very rare effects. So they are encouraging to prescribe ondansetron in the severe and refractory cases. So that's why I didn't take those one, because I don't think so. They're asking something which is now established, that these teratogenic effect is very small and it is not proven. So that's why. Okay, so metoclopramide should be used as a second line therapy because the risk of short-term extrapyramidal disorders and tardive dyskinesia, particularly in the young pupil. So that's why the review recommend metoclopramide should only be prescribed for short-term. Maximum dose is 30 milligram in 24 hours or zero point 0.5 milligram per kg weight in 24 hours, whichever is the lowest. Either you will give the 30 milligram maximum, or either you will give according to the body weight. For example, somebody have body weight of 100 kg. So how much you will give? You will give 50 milligram? No, you will give the 30 milligram, right? This line have, I think, the same, this meaning. Either you will give the 30 milligram maximum dose, but if the patient has 100 milligram, then the dose will be 50 milligram. Then you will not give 50 milligram. Again, you will give the maximum dose of 30 milligram. Okay, whichever is the lowest. This is the meaning of this line. And maximum duration in 5 days. So maybe they will give you the scenario that the patient was discharged on metoclopramide for 1 week duration, and after 1 week she came to you again and she said that my vomiting, and she's still having vomiting. So maybe they will give you option to continue with the metoclopramide or start on densitron or start some other combination, but you don't select the metoclopramide again, because after 5 days you will not continue to give this medication. So it is only for 5 days. And IV doses should be administered by slow boluses. At least you need 3 minutes to help minimize these risks. So whenever you are giving the IV, so they are encouraging to give the slow infusion. Because you dystonic reactions has been less common in non-pregnant patients who are receiving a slow infusions, okay, like bolus injection of 10 milligram. So they are better to put this 10 milligram in the drip and then give slow infusions better. Okay, so steroids should be reserved where standard therapies are failed. So what are the standard therapies? Standard therapies are IV fluids, IV antibiotic first line, second line. So if these, and reassurance definitely, or dietary measures, or there are some other advices. If these standard therapies have failed, then you will consider the steroids. The suggested dose is IV 100 milligram twice daily, and then when clinical improvement occur, you can convert to 40 to 50 milligram daily, and then you will taper it until the low maintenance dose control the symptoms is reached. So it's like that. So in most cases, prednisolone need to continue until the gestational age at which typically resolve. For example, 20 weeks, maybe 20 weeks, the hyperemesis resolved, or extreme cases, this occur at delivery. So I have seen cases in which they have taken the steroids until the delivery, 5 milligrams throughout the pregnancy. They were taking the 5 milligram prednisolone. There are some time of hyperemesis. They are very severe. So what are not recommended? The diazepam is not recommended in the management, and pyridoxine is not recommended for nausea, vomiting, hyperemesis gravidarum. So these four are not recommended. So what is the best rehydration regime for ambulatory daycare and inpatient management? Normal saline with additional potassium chloride in each bag with administration guided by daily monitoring of electrolyte is the most appropriate IV hydration. They're asking this question also, what is the most appropriate IV fluid? So this is normal saline with additional KCl. And definitely you will not put every drip KCl. You will do electrolytes, and accordingly, if needed, then you will add the KCl. But the best fluid is normal saline. And dextrose infusion, they are not appropriate unless the sodium levels are normal and thiamine is replaced. For example, if there is a severe dehydration, if patient come to you with she's having severe dehydration, and in that cases, sometime you need to give the patient hypotonic fluid. Hypotonic fluid is dextrose, and normal saline is isotonic fluid. So when there is this category of dehydration, when there is a extracellular dehydration, including the intracellular dehydration, in that scenario, sometime you need to give the hypotonic fluids, which include the dextrose infusion. So they are saying that if in that situation, if you want to give dextrose infusion to the patient, then along with thiamine, you can give, and when sodium level is normal, you can give dextrose infusion. But routinely, the first line is normal saline, and then if you are replacing, you have to give, if there is a scenario in which you have to give the hypotonic solution, then you will make sure that you have given the bolus doses of thiamine and the serum sodium levels are normal. Okay. There is no evidence to determine which fluid regime is most appropriate, but given that most women admitted to hospital with hyperemesis gravidarum are hyponatremic, low sodium, hyperchloremic, and hypokalemic and ketotic. So low sodium, low potassium, and high chloride and ketotic. Then it seems appropriate to use the normal saline and potassium chloride. Okay, so usually the normal saline and potassium chloride, it is a normal routine, but I think better when you are KCL, for us gynecological point of view, whenever the patient we want to start KCL, we are doing potassium levels, and if it is low, then we are adding the KCL. But anyhow, usually they are telling that majority of cases are having this problem, so it's safe. So dextrose containing solutions can precipitate vernix encephalopathy in thiamine deficient states. So if you each day intravenous dextrose is administered, you will give the high doses of parenteral thiamine should be given to prevent the vernix encephalopathy. The dose is 100 milligram. Okay, so 100 milligram is the bolus dose. Then you have to continue the maintenance dose. In the guideline, it's not written the what is the maintenance dose and how much you will give, but the only thing is that the bolus dose is 100 milligrams. Sometimes this 100 milligram is enough for 1 week, but sometimes you have to give daily doses 50 milligram. It's according to the situation, but I don't think so. They will ask us only the bolus dose is enough. Ginger may be used by a woman wishing to avoid antiemetic therapies in mild to moderate NBP. So in the MCQs or something, they talk about ginger tea, or something they talk about ginger biscuit also. So you can offer to mild to moderate this one. Okay. Ginger may be used with wishing, okay, the same slide, but they write some side effect. They said this might have, if you will give in high amount, maybe anticoagulation effect, stomach irritation, and this one can interact with beta blockers as benzodiazepine. I highlighted this one because sometimes we are ignoring these things. We are giving the patient advices, but maybe patient is taking beta blocker, or maybe she's taking benzodiazepine, or maybe she has a stomach ulcer problem, or maybe she have she's taking some medication, so we don't want this effect. So this is the side effect you have to keep in your mind when you are advising the ginger. If low risk patient, you can advise her that this additional advice, but keep in mind the side effects also.
Excuse me,
Yes,
Dr. Fawzia.
yes, yes.
Yeah, also in ginger, it has a side effect of palpitation.
Uh-huh.
Mm,
Palpitations. Okay.
yeah, palpitation. And you can
Mhm.
notice this when you take strong tea, ginger, you will have palpitation.
Okay. Maybe
So,
that's why they are saying they are interacting with beta blockers because beta blocker
yeah,
will yes
yes,
yeah. Yeah,
yes,
you answer your, but because you see here beta blockers is the function of beta blocker is for palpitation. So when you have this,
yeah, yeah.
thank you. Okay, so stimulations, acupressure, and acupunctures. Basically, stimulations contain acupressure and acupuncture. These are two different things. In acupressure, you are just pressing the specific points in. This is actually the diagram of foot. So in the foot, you can see there is a different points which are pointing towards. There is a stomach point in the sole of the foot. There is a liver point. There is a intestine point. So there are different points. So in pressing those points, acupressure, you will resolve the problem. Or then you have acupuncture. You are puncturing those points, those specific points, which is related to specific vertebral level, your sensation. So it is called the acupuncture. So they can be said that acustimulations, both acupuncture and acupressure, they are safe in pregnancy, but only the acupressure may improve the nausea, vomiting of pregnancy. There is a systemic review and it discussed the efficacy in acustimulation. For example, it contains acupuncture, acupressure, and electrical stimulation. There is a specific area which is called the pericardium 6. In pericardium 6 is located about 2.5 finger breadth up from the wrist crease on the inside of the forearm between the tendon of palmaris longus flexor carpi radialis. So this is the point in your wrist. If you will see your inside of your forearm and come from the your wrist crease 2.5 centimeter below, and it is inside. So there is a two tendon reflex. There is a two tendons. This is palmaris longus and flexor carpi radialis. In between that point is there. So this point is called PC6. Okay. So they said the acupressure applied by finger pressure or wrist bend and electrical stimulation both reduce nausea, vomiting, but acupuncture methods did not. So although it looks very similar, but they said that the acupressure is better and it might relate to decreasing the nausea, vomiting, but acupuncture it is not so effective. So if there is a comparison, then you will want to select the acupressure. Okay, so hypnosis, it is not recommended to manage the nausea, vomiting, and hyperemesis gravidarum. Okay, so what is the monitoring and the adverse effects? So what complications and adverse effects can occur from nausea, vomiting in pregnancy and hyperemesis, and what are their preventive management strategies? So what we need to do, any patient who is receiving the IV fluids, the first thing you will do, you will check the daily serum and electrolytes, because you want to make sure that you are giving the isotonic or hypotonic fluids, or what type of fluids you want to give the patient. And for this, you need urea and electrolytes. And also this will tell you also the degree of dehydration. So histamine H2 receptor antagonists or proton pump inhibitors, they can be used for women developing the GERD, esophagitis, or gastritis. So these the type of drug, proton pump inhibitor, esomeprazole, we are sometimes using in low dose, 20 milligram we are using, or histamine H2 receptor antagonists. I think this ranitidine or I think Zentex. Usually it's not we need to see the data, because they say it can be may be used, but the recent most coming data, they are not so convincing about histamine 2 receptor antagonist. But anyhow, the safest one is esomeprazole. We can use this one. And then there is a thiamine supplementation, either oral or intravenous, and it should be given to all women with prolonged vomitings, especially before administration of dextrose or parenteral nutrition. So here the parenteral nutrition, before we need to give thiamine supplementation. Okay, we already discussed that if the patient will have severe epigastric pain, which is the buzzword, I told you the buzzword, okay, and there is another buzzword, if there is a hematemesis, then in this case, for diagnosis, you can offer the patient esophageal gastroduodenoscopy. Sometime if you don't know the answer, maybe they want you to select gastroenterologist better, because they know better what is safe, or what is no, no, they know better what is the best option for the patient with hematemesis. But as a gynecologist, you should know that for the counseling of the patient, because you're the first line clinician, that during the pregnancy the gastroduodenoscopy is safe. So therapeutic trial with proton pump inhibitor is appropriate for the treatment and prevention and safe in pregnancy. You see here they talk about proton pump inhibitors, but histamine H2 receptor antagonists you can be used, but if the patient have something established, for example, she has GERD, she has esophagitis or gastritis, like some chronic GIT problem, along with that you can use. But for the routine nausea vomiting of pregnancy and for the hyperemesis, if the patient don't have these symptoms, maybe you don't want to give this one. Women admitted with hyperemesis should be offered thromboprophylaxis unless there are specific contraindications such as active bleeding, and when the patient, because this is transient risk factor, when a patient will be discharged, you can discontinue. And also patient which she has previous or current history of nausea vomiting, you should consider iron containing preparation, because it can exacerbate the symptoms. So in the first trimester, usually we are not recommending because of nausea, vomiting. Already we are not giving, just because of this fact that patient will have vomiting because of iron in the first trimester, and she will not have absorption. So you have to be okay. Further management. What is the role of multidisciplinary team? You sometime I have one patient, very resistant case, and she was she was dehydrated, electrolyte imbalance, we are giving KCl. Even I started for her on densatron, even I started for her 8 milligram 8 hourly, which is the maximum dose. But still then there was some problems, like now I have to involve the other modalities, and I called the internal medicine, and they said no, this is not our case, this is gastroenterologist case. So whenever these are the things, you have to actually know whom you have to call. You have to call the gastroenterologist, because they are the one to manage the case, this one, because maybe they will rule out the other causes, gastritis, GERD, or esophagitis, or liver disorders may be associated, or they are the best one to give you the advice in these patients. And also nutritionists definitely, and then endocrinologist, because maybe associated the thyroid problems, or maybe associated maybe diabetes, or pharmacist, because they will tell you the drugs doses and which drugs you can use maximum, what doses, they are the one. Midwives, nurses, dietitians, and the mental health team, including a psychiatrist and psychologist both. You need a psychiatrist to give the medicine, and the psychologist also. Maybe sometime these patients, because of our, they are saying in the guideline, because some majority of the healthcare professionals, sometimes they are saying the patient is making herself the symptoms, she is psychotic, and she's making herself more problematic, or look, this patient is coming again and again. And we are thinking the patient is herself is a problematic, she has some psychological problem, but because this disease is so much debilitating, that it has been compared to other debilitating disorder like asthma or chronic illness, that patient, because of chronic illness, she will become some psychological issues also, because of problem, not because she's having some psychological issue and she's just exaggerating her symptoms. No, because of disease she develops psychological issues. So it's written very clearly in the guideline. When should enteral and parenteral nutrition be considered, and what are the risks to the mother and the fetus? So there is no definite criteria. First of all, no definite criteria for parenteral, IV, or enteral feeding. So effectiveness is not established, because there are some side effects also. So what are the enteral feeding? You should know the gas. There is NG tube, by NG tube, nasogastric tube, or by nasoduodenal tube, by nasojejunal tubes. So there are any tube which can go to the gastric, duodenal, or jejunal area. These are the tubes. Or sometime you can just do percutaneously endoscopic gastrotomy or jejustomy feeding. So these are the things. So parenteral feeding, which is IV, they will put some peripherally inserted central catheter, which is called PICC line, and it is better tolerated than enteral feeding. So they said parenteral is better tolerating than this enteral feeding. But they said the parenteral feeding definitely it is a IV line, so it risk of infection and vascular perforation is there. Enteral feeding more effective and safer than parenteral feeding. Now again here they're saying enteral feeding is more safer. Parenteral feeding, they said it is better tolerated. So now there is a difference between toleration, affection, and safety. So enteral feeding is more effective and safer, but parenteral feeding is more tolerable. It's better. Any patient will have less feeling, less side effect, and but enteral feeding is more effective source of nutrition, and it is safer than parental feeding. Here I want to discuss one SBA, which is called the refeeding syndrome, a very common source of discussion nowadays in part 2 groups. They are discussing that there was a question in the exam, and it came that because the patient have which electrolyte will be low because of refeeding syndrome. Anyhow, the refeeding syndrome is the syndrome when you are giving the patient you restart the feeding the malnourished patient, then there is changes in the body, and at the end of this changes in the body, because you are putting the loads on the hormonal system of the malnourished person. So what will happen, what will happen, there will be immediately, because potassium will go inside, it will cause hypokalemia. Also the magnesium will be low, and the phosphate will be low. So they were asking that because in refeeding syndrome, there is because of there was initiation of the cycles of the hormones, which will at the end of the day it will cause the hypokalemia, phosphatemia, and hypomagnesemia. So which one is the most common, or which one will be the more prominent? So in the refeeding syndrome, the phosphate level will be the most prominent symptoms. So you have to replace the phosphate, or you have to do, or you have to take care of this thing also. So this is the exam question. Usually one in our mind, we are thinking that maybe because potassium is the intracellular electrolyte, so maybe it will go whenever there is a you will correct the electrolytes, it will go inside, and first thing it will happen hypokalemia. But it will happen hypokalemia also, but phosphate is the major electrolyte which will be affect, and refeeding syndrome hypophosphatemia is the answer. Anyhow, I will share the picture also, very nice picture of the metabolism. But when you will read the nausea vomiting of the pregnancy, and in the exam you will have this question, the refeeding syndrome, which electrolyte will be the most affected, and then you will be surprised that there is common sense. Only in the exam the common sense. Even if you will the common sense, you will use the potassium, maybe you will use everywhere will select the potassium because hypokalemia, but the answer was hypokalemia, sorry, hypophosphatemia. Okay, so in some women, intragastric feeding by NG or percutaneous endoscopic gastrotomy tube, it increases the risk of nausea and vomiting. So short term, it can be tolerated, but not in the protracted hyperemesis gravidarum. So they said in the short term, you can just use for the short term phases, like by you can pass the NG tube and give the feeding to the patient. But this one only with the nausea and vomiting. But if there is hyperemesis gravidarum, this NG tube feeding, it's cannot be tolerated. In nasojejunal feeding, they said you can the tube is inserted endoscopically, and you can do continuous infusion. And again, there is a problem with this. Problem is because when there is a when there is a vomiting, these tubes can be dislodged. Okay, so at the end, I want to tell you the complications of this tube dislodgement, and it can obstruct or migrate. And there is abscess formation, fistula formation, pneumatosis, occlusion, intestinal ischemia. All can happen with this enteral feeding as a whole. So total parenteral nutrition you can use in the refractory cases to ensure sufficient caloric intake, but it is a last resort, and when all the treatment has been failed, because this is inconvenient, expensive, and there is definitely risk of infection and metabolic disturbance and thrombosis. And they say total parental nutrition, risk of perinatal morbidity decrease. A strict protocol with careful monitoring is essential when undertaking the total parental nutrition. I just put this line, maybe with this one, total parental nutrition, risk of perinatal morbidity decreases. So that's why I took this line. When should termination of pregnancy be considered? Okay, so all therapeutic measures should have been tried before offering termination of wanted pregnancy. So wanted pregnancy, nobody want to terminate. So what is the situation? So the Hypermesis Education Research Foundation in the USA report that 10% of pregnancies, they are complicated by hypermesis, result in termination, who would not otherwise have chosen this. So this is a planned pregnancy or wanted pregnancy, termination rate is 10%. So treatment option should be considered antiemetic, steroids, enteral and parenteral feeding, and correction of electrolytes should be considered before deciding that the only option is termination of pregnancy. And what they are saying, the decision should be by multidisciplinary documentation of therapeutic failure if it is the reason for termination, and women should receive counseling. And after a decision of termination is made, you have to see the prominent reason. Sometimes they have this problem that 66% of cases they terminated the pregnancy. Maybe they will ask in the exam what is the most common cause of termination of pregnancy in the wanted pregnancy. So maybe this is the one. This is the most common cause, because they are unable to take care for their family or their themselves. So this was the most common cause. Another cause is they fear that. Can you hear me?
Yes, we always.
Okay. Okay, so they fear that they or their baby could die. So this is the second most common
Reason.
cause. Hmm? Sorry.
What's the common cause?
Common cause is inability to take care for the family and self-care. They cannot take care of themselves or they cannot take care of their family. This is the most common cause for termination of pregnancy. Okay, so it is 66%,
Okay.
almost two-third of the women. So maybe they can ask two-third. Okay, so fear that half of the women, they fear that their baby would die. This is 0.5% of women, or one third, almost not one third, one fifth, one fifth, almost one fifth, that the baby would be abnormal. This is also fear. They fear that baby, because of repeated vomitings, maybe baby will abnormal because of repeated vomiting and medications. A negative attitude from their caregiver, because sometimes they are not giving because they have recurrent hospital visits, maybe the negative attitude from their caregiver. And occasionally hyperemesis or treatment may lead to life threatening illness, sometimes even with
My
a
voice is interrupting.
uh-huh. That's why I'm asking that my voice. Okay, now because my internet is giving me that it is it clear now?
Hello, no voice.
No voice. is is this problem with all the persons, or maybe only one person? Maybe anyone who can listen to my voice very clearly? No. No one can listen to me. Now you can see or no?
No, ma'am.
No.
No.
Yes.
Yes, we
Yes,
can
we
see
can see
now.
now.
Yes. Yes.
Okay, fine. Okay, so we are discussing the prominent reason. Okay, so negative attitude from the caregivers, this is also one of the reason. And also sometimes you are giving the treatment, and treatment can lead to the life threatening illness. For example, if you are giving some parenteral treatment and the patient have because of treatment there is a complication, so because of that complication you need to terminate the pregnancy. So not only the disease itself, the treatment sometime can also lead to the problem. Discharge and follow up. So discharge, nausea, vomiting, and hyperemesis should have individualized management plan when they are discharged. So with severe or hyperemesis, severe nausea, vomiting, or hyperemesis, who have continued symptoms into the late second or the third trimester should be offered serial scan to monitor fetal growth. So don't forget about the fetal growth because of repeated vomitings. They can ended up in the SGA baby or low birth weight babies. So there is a study that they have shown, and they have seen that if the patient during pregnancy she gained less than 7 kg weight, it's associated with preterm delivery and low birth weight. Also, the women with the severe hyperemesis who require repeated admissions, they have 18% risk of SGA and low birth weight baby than the baby of women with hyperemesis gravidarum in single admissions. So recurrent admissions because of severe hyperemesis gravidarum, the risk of SGA or IUGR baby is 18%. Okay. So what is the effect of nausea, vomiting, and hyperemesis in the postnatal period? The patient with previous hyperemesis gravidarum should be advised that there is a risk of recurrence in the future pregnancy unless they are married to the second partner. Then it will be 10%. Then early use of lifestyle, dietary modification, antiemetics, precautionary, because you will tell that because last pregnancy you have, now in this pregnancy, you have to do early lifestyle changes because from as soon as you will get pregnant, because from 4 to 7 weeks, the symptoms will start and peak at 9 weeks. So they in the index pregnancy, they have seen that if they will advise this thing, early use of lifestyle or dietary modification, it can reduce the risk of nausea, vomiting, and hyperemesis in the current pregnancy. And again, why I write again 15 to 81% this recurrence rate. Okay, what is the effect of nausea, vomiting, and hyperemesis on quality of life? So, women quality of life can be adversely affected, and so practitioners should address the severity of the patient's symptoms according to the quality of life in social situation. And also mental health assessment is also very important, and they should refer to the patient psychological support if necessary. So if they in the exam patient, they are talk about patient is very anxious, patient is very distressed, and she's having, she told that she is suffering from mentally, then in this case, don't forget the psychological support because this is a multidisciplinary team management. Always don't forget multidisciplinary. And also source of psychosocial support. Also the practitioner, they should validate the woman physical symptoms and psychological distress. They should not dismiss the symptoms. Okay, so first line medicine, no need to you have to memorize the doses. Just you need to know which is the first line, second line, third line. The first line is cyclizine, prochlorperazine, promethazine, and chlorpromazine. So these are the phenothiazines. Okay, and the second line is we already discussed metoclopramide and domperidone. These are the dopamine this antagonist, and then ondansetron. Ondansetron, it is coming under the name of I think Zofran, something like Zofran. And the dose is either you can give 4 milligram 8 hourly. Actually, I want to start my patient 8 milligram 8 hourly. So the my sister, she become very surprised. She said she didn't allow me to give 8 milligrams. Sometime you have to fight with your sisters also. She so you can give 8 milligram, even 6 hourly you can give maximum dose. So, but here the rule is you have to start from the low doses. You have to start from the 4 milligram 8 hourly or 4 milligram 12 hourly. Then gradually you can increase the interval and you can increase. This 8 milligram, anything you will give, you will give over 15 minutes. 8 milligram over 15 minutes, 12 hourly IV. So this is the usual thing we are giving 8 milligram IV 12 hourly. We are giving like that. But orally, they are giving it this one. For orally, this is 4 to 8 milligram. I think the dose of IV is different. 8 milligram over 15 minutes, 12 hourly IV. The IV dose is 8 milligram 12 hourly, and oral dose you can give 4 to 8 milligram 6 to 8 hourly per orally. Okay. So I understand now why my sister, she was surprised. Okay, because she want to start from 4 milligram 12 hourly. Okay. The third line is steroids, hydrocortisone 100 milligram twice daily, and then clinical symptoms will improve 40 to 50 milligram daily. Then you can gradually taper the dose until the lowest dose achieved. So these are the first, second, and third line. Just remember the phenothiazine is the first line, all the phenothiazine, and the second line is this one, dopamine antagonist and ondansetron, the second line. Third line is steroid. Okay. Where are the, okay, this is the, so this is the PUC score. This is a 24. PUC 24 mean 24 hours, last 24 hours, they're asking last 24 hour symptoms. So these are 3 questions, and every question they are marking it 1 number, 2 number, 3 number, 4, or 5 numbers. If you ask in the last 24 hours, because it's a questionnaire, so you will ask, okay, in the last 24 hours, daily basis, you are going to your patient and said, since yesterday, how many times you feel nauseated or how many times you sick to your stomach. So that she will tell 1 hour, 2, 3 hours, 4 to 6 hours, more than 6 hours. Accordingly, you will give the numbers. Okay. And if you will ask how many times she threw up or she vomiting, if she will tell I didn't throw up, then you will give her 1 number. But if she will tell 7 or more, it is the maximum number 5. In the last 24 hours, how many times have you have retching or dry heaves without bringing anything up? So if she will tell no, no, it's mean 1 number. And if she said 7 or more times, then it's mean 5 number you will give. Okay, so this is how you are going to do scoring. I think in the exam, they will just give you the collective data that you have to remember. If the PUC score is 3 to 12, that's mean no complications. What you can do antiemetic in community, and you just advise lifestyle and dietary changes, reassurance, and oral rehydration. This is the thing. Okay, and if the PUC score is 13 or more than above, and no complications and no refractory to antiemetics, just ambulatory daycare management until no ketonuria. Because remember what was the ambulatory care criteria, that patient has nausea and vomiting and she cannot keep so in that case we will admit her in the ambulatory daycare, but she should not have complication, because if complication like any infections, or if she has developing ketonuria because she's not able to keep anything oral and she's refractory to antiemetics, then you will this PUC score yani this, if no complication and PUC score is 13 or above but without complication, then you can manage ambulatory. But if there is any complication, any PUC score, but a patient have complication now she has infection or she has ketonuria or she's very fulfilling the criteria for this one inpatient management, then any PUC score you will admit the patient, or unsuccessful ambulatory daycare management, you will admit the patient inpatient management. So these 3 you should know by heart, because in the exam they love to ask this question, that you will select the ambulatory daycare, or you will select the usually the EMQs are coming, and in this option you have to select the best option for the patient. Okay, so maybe they will give you the combination, but the main thing is in your mind you have to think, is it complication Okay, if any complication, admit the patient. Whatever the PUC score, they want to confuse you. Maybe they will say the patient PUC score is 4 and patient have UTI and patient have vomiting. But if she has UTI, then you will have to admit the patient because you want to give them maybe IV antibiotic, because oral antibiotic maybe she cannot take because of her vomiting. And any infection in the pregnancy, even in UTI, can lead to the pyelonephritis. So you have to remember that any PUC score with complication, you have to be admit the patient. Also, initial assessment, what you will do, you will exclude other causes, you will do PUC score, you will assess for complication, dehydration, electrolyte imbalance, weight loss, and offer advice. Okay. So, ambulatory daycare management, fast IV fluids with normal saline and potassium with no contraindication. You will give the antiemetics and you will give the thiamine. Even thiamine you can give in the daycare management, because you just need to give one bolus dose 100 milligram and it will be enough for 1 week. Inpatient management, as for ambulatory care management, plus you will give IV fluids, normal saline, antiemetics, thiamine, and then you will give thromboprophylaxis. Now you will involve the multidisciplinary team and you will consider the steroid, the third line. So that's mean ambulatory care, daycare management. Even you can use the second line treatment also. Even in the this what it mean, that even on densatron you can use in the ambulatory daycare, unless the patient have no complication. Even the second line drugs you can use. This is what this graph is meaning. That for as for ambulatory, consider steroids. So they are considering inpatient management. They are considering steroid. Okay, so I think that's it. I tried during the lecture to cover all the SBA I came across. I didn't find any other SBA which is not covered in this lecture. If you have any question, you can ask.
Excuse me, ma'am.
Mm-hmm.
I mean, sometime when we are reviewing the question in different groups, this ketone urea plus 2, they are not specifically mentioning the POC score, but ketone urea, there is always some confusion. Because if they will write clear cut that there is some complication like UTI or some other complication, we can go for in patient. But sometimes there is always confusion regarding the ketone ureas. So can you explain please that?
Ketonuria is not always the indication for admission. We have to remember this thing, okay? Because sometime when a patient have just dehydration and she has ketonuria, and you in the community care, or because in the community care you will oral dehydration only. So in this case you want ambulatory care. In the ambulatory care you will give the IV fluids to the patient and you will repeat the ketones, and in on the repetition sometimes the ketones they will go on, because ketones are just only because of dehydration. Okay, so only ketone urea is not the indication for admission. Okay, this is a sign of dehydration. But if the ketone urea is severe, it is 3 plus, and patient have another symptoms, for example she is giving you electrolyte imbalance, she is giving you the weight loss history, and she is giving you the continuous vomiting refractory to treatment with ketone urea, then you will admit the patient in patient management. So after this guideline, we started to change our practice, and before, whenever there is a ketone urea in our ER, we were admitting the patient because we are thinking ketone urea is the indication for admission. But now you have to see ketone urea is might be only because of dehydration. You admit the patient in the daycare, rehydrate her, give her antiemetic, and repeat the ketones. If ketones become better, that means she need only rehydration, and after antiemetics you can safely discharge the patient home. And if electrolytes are normal, if she don't have weight loss, if she don't have protected continued vomiting, and if she can tolerate the oral intake, then you can discharge the patient at home. If she is fulfilling the criteria of inpatient management despite all treatment, still she is unable to tolerate the oral fluids, and she has ketone urea, she has other indication for inpatient management, then along with other criteria, then you will admit the patient. But ketone urea alone is not an indication for inpatient uh, this admission.
Okay, thank you, ma'am. Thank
You
you.
understand? Because because we
Yeah,
also
yeah.
have changed our management because of ketonuria, because we know our resident, any patient with ketonuria, khalas, admit the patient. No, now no. We will just give the IV fluids in the ER. We'll see, we'll repeat if ketones improve. If she have no other risk factors, for example, the blood sugar is normal, no infection. And this always remember this table. And if electrolytes normal, she become better clinically, discharge the patient. Okay.
Okay. Thank you, ma'am.
Anything else? Any question?
Ma'am, this enteral and parental, a little bit confusion. Which
Yes,
one is
little bit
best? And
confusion. Yes, I will tell you one thing. They are not going you to ask you this parental and but maybe only anything. The detail they will not ask you because this is subspecialty. There is a specialist care. Only thing you need to know that you need to consult the patient that you might need parental therapy, you might need enteral therapy, and which one is more tolerable, which one is more effective and safe. These are the thing more important as for you. For this complication and which one is to give, which one not to give, what are the possible complications, this is not our, this is not at all related, this is not out of scope for us. We just need to know that before yani, uh, involving the other teams, we need to consult the patient. Maybe you need this one, this one, this one. Maybe it is associated with complication, but exactly how much we don't know because we are not dealing with them. So just I don't think I never saw something related to parental nutrition recalls. But if you have any question from the recalls on this one, you can share with me. You have anything?
no, ma'am.
Yeah.
Just because when we read the slides and guidelines with you, when you are explaining, you explain very nicely, but still parental and some confusion. So when we will read again, it will fix our
Just
knowledge.
remember, you
Which one
see,
is better?
enteral feeding,
Which one is
yeah.
better, and which one is safe? This is the only thing I got, that we have to concentrate. Which one is better and effective, and which
Yes,
one
this
is
is the only thing
best
you need.
tolerated?
Yes, this is the only thing you need to know. Parental feeding is this one more tolerable, but the enteral feeding more effective and safer. Okay, this is the only
Okay,
thing.
thank you.
And this NG tube, angioduodenal, angiojejunal, who will decide? I will not decide. The one who put, they will decide, right? So I have
Thank you.
not to bother. I just to bother. She need enteral feeding or she need parental feeding, and I will tell the patient now we have to offer you, we have two options. So
Hmm.
parental also and enteral feeding. If she will refuse or there is a problem with the IV lines and she's needle phobia, maybe they want to direct you towards the enteral feeding, just they will just superficial. Just you need to select
Okay.
which one. Don't go into the deep, just superficial which one. Parental or enteral, that's it.
Thank you, ma'am.
Okay. Okay, any more questions? Okay, after that, now I decide to do this one, legal and ethical issues, because I share in the group, there are maybe 15 talk articles related to these topics. These are risk management topics, audit, and the statistics, and the consent, and because they are always in the exam, one question is coming from the consent, 100% it will come. And also the questions from the clinical governance, risk factor. Yani, you are 15 candidates now. You have read any of these talk articles, because I, before presenting my this one presentation, I want to know exactly the level of knowledge you have. Okay. So do you have any idea? You don't have any idea. Just give me the number from 0 to 10, that accordingly I will prepare my slide.
No idea, ma'am. Sorry.
Okay, so you are the one rest 15 participant. Can you just give me that you have ideas for ethical and the medical legals and issues, clinical governance, risk management, audits, all those? You have idea, or what type of
No,
presentations you want?
madam.
No, not at all. Not at all, or you have some idea, yani at least two, three, four, you at least you know the names, or you know the consent, you know the recalls, what type of recalls are coming. Yani,
Just tidbits
We
of
just know very
tidbits of
superficially,
name
ma'am.
or something.
one by one,
Ma'am,
one by
40-50%. I have got 40-50% of idea about that.
You have 40-50%. Okay, so you must know that in the exam the questions are coming like that. Usually the age related, usually the 16, below 16 or 16 to 18. There
Yes,
is
ma'am.
two groups, yeah. These type of
Yes, ma'am.
questions.
Gillick and
Yes,
yes, and Felix
ma'am, I
and
also have idea,
You have idea?
bit idea. Yeah, ma'am.
You have
I
About
idea.
have
facial
idea,
gray
like
and
it's, but the knowledge is very superficial, ma'am.
yeah,
Okay,
but superficial.
superficial knowledge, but the consent, if, how many of you have read the TOG consent article 2015? Because in that one, the consent, at least many confusion related to consent scenario, it has been cleared. So how many of you have read that consent TOG article? Because what is the benefit of all of you have read already? Because if you once you will read, all the confusion will be gone. Okay, so that's why I asked somebody to make a word for me, word slide, because the making the beautiful slides, it will take time. I don't have time now, my vacation or khalas, it's already finished now. So if you just make me word, and I will change into the presentation. So you read that article or no? Consent.
Still yet to read, ma'am.
Okay, fine. So, okay, then I will prepare the slide if you have not read, because this is very important TOG article. In consent, there are many confusions and they have cleared. And I am preparing from strategy. I will recommend all of you, please. I know it's very expensive, but please buy the strategy, because now they have changed everything. They have changed the way they are presenting now. They are presenting in the video styles every topic, because yesterday I want to cover the medical abortion, and it was a very big module. The medical abortion before 12 weeks, medical abortion after 12 weeks, and then medical abortion contraindication. There are many things. So I thought, first of all, I thought I will give you lecture on the abortion care. Then I changed my mind, because if I will start that one, maybe 1 week it will take to me. It is really for me also to prepare the slide very difficult. Then I thought I will do this one, recalls, the one related to legal and ethical issues. The most important thing I want you to ask, please, go into the recall folders, and if you find any question related to the ethical and clinical governance or audit or something related to this topics, just collect this one for me for the class, because after we will read, we will do questions, because reading is not enough, solving the question is the main thing. And this drug, I think it is something sound like pro uh, cyanide or something like that. Really, until now, nobody give me the answer, right? I will share in the group. Okay, after finishing class, I will share in the group the antidote of extrapyramidal effect. Okay. Okay, thank you for your time. I will end the class now. Okay.
Thank you very much,
Thank you,
ma'am.
madam.
thank you so
Thank you
much.
so
Thank you
much
for your effort and your
for
time.
your
Yeah.
time, actually.
Yeah.
Thank you
Okay.
very much, ma'am.
Let me first one by one. Let me stop the recording first. Yes.